Welcome to the webcast, Treating Elevated Protease Levels in Wounds. This program is sponsored by North American Center for Continuing Medical Education and is supported by an educational grant from Cystogenics. Today we'll be speaking about treating elevated protease levels in chronic wounds. I'm Tom Serena. I'm the founder and chief executive officer and medical director of the Serena Group, a family of wound and hyperbaric centers. My goal in speaking to you today is to explore emerging methods to detect elevated protease levels in wounds. And I'm going to use the term EPA, and that stands for elevated protease activity. I know here in the U.S. EPA stands for something else, but this is a very common international acronym, and hopefully the wound care community will adopt it. In addition to detecting proteases, we're going to back up a little bit and talk about inflammation in the wound, about how the proteases in the wound affect healing. We'll go over some key principles in treating wounds with elevated protease activity, this EPA, and we'll use the term protease modulation. We'll describe the role of collagen ORC with and without silver in reducing protease activity. Please remember that to receive continuing education credit following the conclusion of this activity, each participant must complete the post-test and evaluation, which can be easily completed online for immediate receipt of your credit at www.NACCME.com. That's NACCME.com. Let's go ahead and get started. If you're listening to this presentation and you're considering continuing or entering the wound care world, you're in a good place. 3% of the adult population, according to the government statistics, over the age of 65 has a wound. Now, not every one of these patients needs specialized care, but that's a lot of folks. That's 10 times the incidence of cancer. And this is my grandmother. She just passed away at 106, and our population is aging. In addition to that, if you add diabetes and obesity, wound care is going to be a very popular specialty in the future. There are some worrying facts. If you look at this, you see that there are enormous numbers of patients with diabetes worldwide. You see on this fact sheet that it says 246 million people living with diabetes worldwide. It's estimated that'll be 400 million by 2025. It's a very large percentage. And these patients have a significant morbidity and mortality just associated with having an ulceration. A diabetic foot ulcer is the most common complication of diabetes. Venous leg ulcers are even more common than diabetic ulcerations, and these painful, draining ulcers affect over 1% of the world's population. Now, we know the wound healing cascade, and I'm not going to belabor this. We know that in acute wound healing, we have inflammation and then proliferation or reconstruction, followed by remodeling, and you can look at the time frame on the axis there. What we're really going to concentrate today is on that first part of the wound healing cascade, inflammation. For a chronic wound, one that doesn't proceed naturally from inflammation to reconstruction, they're stuck in the inflammatory phase. It's like the movie Groundhog Day. Every morning the wound wakes up and it's in inflammation. We're going to talk a little bit later about why this happens and what we can do to try to get wounds from the inflammatory phase to the next phase of wound healing. This is the same diagram shown with arrows, and you see that where impaired wound healing occurs is in that inflammatory part. And we'll talk about host proteases and bacterial proteases as well. When you look at wound healing, there are a lot of potential underlying defects. There can be a damaged extracellular matrix. There could be a paucity of growth factors, or growth factor receptors may not be expressed. The wound may not have enough nutrient oxygen. There may be infection or high levels of bacteria. It may be biofilms. There may be high levels of inflammation. The epithelium may be non-migratory, just not working very well at all due to senescent cells. But we're going to focus today on one of the main reasons that wounds don't heal or they stall, and that is elevated proteases, or high proteases, it says on this slide. It's a vicious cycle. You have delayed wound healing. The excess proteases damage tissue that releases further free radicals and causes further production of proteases. In other words, it goes round and round. Once you have elevated protease and in an inflammatory environment, it just keeps cycling, making things worse and worse. And as a result, the wound doesn't heal. Chronic stalled delayed wounds exhibit elevated proteases, and we'll talk about MMPs and elastase in a minute. They have a tendency towards bioburden, increased bacteria, or even outright infection. They have increased in the number of inflammatory cytokines, and yet there's decreased numbers in growth factors that are needed to heal, and the cells themselves are not proliferating or producing collagen and other products that are needed to heal the wound. So let's look at proteases and wound healing specifically. And we're going to also define elevated protease activity and the acronym EPA. So let me just ask you a question first. Proteases are synthesized and stored as A, inactive proenzymes, B, active proenzymes, C, TIMPs, which is tissue inhibitors of matrix metalloproteases, or AATs. When we look at inflammatory cytokines in wound healing, first, now you may say, well, we're going to talk about proteases. Why am I talking about inflammatory cytokines? Because it's the presence of these inflammatory cytokines that cause the host cells' tissues to produce the MMPs and neutrophil elastase and the other harmful proteases that break down the wound. So we look at inflammatory cells are stimulated by a variety of different things in the chronic wound. These cytokines are then produced by macrophages, neutrophils, and just damaged skin cells. And that leads to a number of these inflammatory cytokines. And there's an alphabet soup on this slide. I realize that. But don't worry about so much about the actual acronyms. Let's worry about the fact that these inflammatory cytokines are produced. And the presence of these cytokines is going to increase the production of these proteases at very high levels, which is going to be harmful to wound healing. If you look at the role of inflammatory cytokines in normal situations, they're important. They activate inflammatory cells. They regulate protease production. They're chemotactic for wounds to get them into the site. You know, macrophages normally swim around in the bloodstream as circulating monocytes, and they need to leave the circulation to enter the wound to help the healing process. So in the normal situation, these inflammatory cytokines are beneficial. As I've already mentioned, in response to these inflammatory cytokines, the cells in the wound, I've listed them there, will produce these matrix metalloproteases or neutrophil elastase. These are host proteases, and I make a distinction here between host proteases. Those are the ones where the body itself produces these proteases in response to the inflammatory cytokines. There are also bacterial proteases, and I'm not going to talk about bacterial proteases today, but they're important as well. And this is bacterial proteases are how the bacteria in the wound will damage that host wound. But they're very different. And when we talk about inflammation, we're primarily going to talk today about these host proteases. Again, the MMPs and neutrophil elastase that are produced in response to these inflammatory cytokines being present in the wound. So let's jump to MMPs. These are proteases. They degrade proteins. There are a number of different categories. The next slide will actually show you the variety of the different categories. They're normal. You need to have MMPs. They function optimally under normal physiologic conditions, and each of them will degrade a certain component of extracellular matrix. They're controlled normally and naturally by inhibitors, the TIMPs and AATs. These inhibitors of MMPs form a balance, and in normal wound healing, when you don't have the stall in the inflammatory phase of wound healing, there is a balance between the TIMs and AATs and these matrix metalloproteases. And that's how, in the normal situation, things are controlled. Chronic wound is going to be very different, as I'll show you in a bit, where we have elevated levels of MMPs and we have decreased levels of the inhibitors of those MMPs. MMPs have a number of different families, and there's over 20 different members. For those of you who may have an interest in investigating this a little bit further, I've included a number of different categories. The collagenases, which would be the primary one being MMP8, and then gelatinases, the primary one being MMP9. You know, it's interesting. You may speak to your colleagues about these MMPs and find out that MMPs are important in a lot of disease states. For example, as a vascular surgeon, we were concerned about MMP9, that gelatinase, in the development of abdominal aortic aneurysms. And there are now clinical trials ongoing to decrease MMPs in abdominal aortic aneurysms to see if we can prevent the progression of the AAA or AAA abdominal aneurysm. Now, when you look at wound healing and the role of proteases, they're important. They activate growth factors. They cause fibroblasts to migrate. They cause keratinocytes to break off from the edge of the wound and start growing across the wound. They help debride the wound. They help in migration of inflammatory cells and cleaning bacteria out of the wound. So they're important. We need to have proteases. We don't need is too many of them. So let's go to our new question. Matrix metalloproteases are necessary for normal wound repair because they enable all the following processes except A, activating growth factors with the extracellular matrix, B, degradation of the extracellular matrix at the time of injury, C, reorganizing the extracellular matrix to improve wound tensile strength, and D, cellular inactivity towards the site of a wound or injury. So if you look at that, most of this we've already answered. We know that MMPs activate growth factors. They're important in degrading the extracellular matrix, and even in the reorganization phase of wound healing, they will help us to improve wound tensile strength by breaking down assisting in breaking down collagen and then relaying it. So obviously, this answer would be D. Now let's look at chronic wounds, and we see in a normal wound healing, you see this increase in protease activity, and that's beneficial. It's the MMPs, the neutrophil elastase, doing all the things that we need them to do. But then quickly that level falls down back to baseline. In a chronic or stalled, difficult-to-heal wound up in the green there, you can see that we have a marked elevation in protease activity, and it doesn't fall off. It persists. And we're going to need to decrease that protease activity if we're going to make a difference in our wound healing. Brita Cullen's done some work on a variety of different types of chronic wounds and looks specifically at MMPs and neutrophil elastase, and what you can see is that in venous ulcers, diabetic ulcers, pressure ulcers, you have a marked elevation, EPA, elevated protease activity for these types of wounds. And in addition to that, a protease produced by neutrophils, neutrophil elastase, is also markedly elevated. When you look at chronic wound fluid, in particular the MMPs, you see a predominance of MMP numbers 8 and 9. And I will tell you that some of our diagnostic tests that people are developing are really focused on detecting these two proteases. Neutrophil-derived elastase is another one of these inflammatory proteases that will slow the wound healing. Now, it's produced by neutrophils, and it's important in normal wound healing, just like the MMPs are. But in chronic wounds, the neutrophils are overstimulated. They produce too much of this neutrophil-derived elastase, and as a result, this further delays and stalls wound healing. Why did we choose detection of proteases as a potential point-of-care diagnostic? Well, there are more than 30 papers in the world literature that demonstrate that elevated proteases have a negative impact on wound healing. So if we could figure out which wounds had elevated proteases, we think that we'll then be able to target our therapy. So I'm not going to go over all of these papers that were published. I just included a few here. Here's one by Greg Schultz that just shows the same thing. When you look at collagenases in a variety of different wounds, they're markedly elevated. Chronic wounds have lower levels of inhibitors of proteases. And on the next slide, you also see that there's the same thing is true of elastase and alpha-1 antitrypsin. In other words, there's a lot of evidence that in chronic wounds, elevated proteases are present, and that by reducing those proteases, we can affect wound healing. Well, the first question is, how high is too high? And what we had to understand first was, at what level of elevated protease activity, EPA, do you have a decrease in healing? And we're fortunate that the curves are shaped like they are, because you can see it was pretty easy for us to find a spot where there was delayed wound healing and elevated protease activity. So let's jump to a question. Recent data suggest that a chronic wound with EPA has a blank percentage probability of non-healing, or is a difficult-to-heal wound, and that is if we don't do appropriate intervention. So A would be 10%, B 30%, C 60%, and D 90%. So let's look at some of the data. When we look at elevated protease activity and we correlate it directly to healing status, and the power on this one is on this particular study as we published was 93. We've now done well over 1,000 patients looking at these variety of different protease levels in wounds. And this particular study, what we're able to do is correlate healing. So you can see 90% probability of non-healing, and that is 90% of the wounds at that level aren't healing. And we use this finding to set the sensitivity for the test. So if you look at elastase activity and look at MMP activity on this 28%, 90% rule, what we find is that at a certain level of protease activity, whether it's MMPs or elastase, the wounds are not healing. And when we looked at who are these patients that have elevated protease activity, so about 28% of non-healing chronic wounds have EPA. So if you're sitting in the wound clinic and you're about a third of the patients that you're going to see during a day like that, a little less than a third, are going to have EPA. If they have EPA, there's a 90% probability that they're not going to heal without appropriate intervention. So that's the answer to the polling question I just asked. That is, if you have EPA, if you're one of the 28% of patients that has EPA, then there's a very good chance that your wound's not healing. And we've been able to correlate EPA with wound healing status now in several additional studies. One way to remember this, or the way I like to remember it, is 28% of the patients who come into the clinic will have elevated protease activity, and 90% of those patients who have elevated protease activity are not going to be healing. They're stalled wounds. It's a way for us to discover stalled wounds. You know, Rob Snyder and I did a survey study, which I thought was really interesting, and that we looked at patients who had elevated protease activity, and we actually showed photographs to practitioners and actually thought leaders in the wound care world, and we said, is there EPA here or not? And it turns out that the accuracy by clinical examination of detecting EPA is not all that great. There are some clues, but for the most part, you really cannot tell if there's elevated protease activity, and that presents a problem. So when you look at the various etiologies that we deal with in the wound clinic, you can see that if you take all non-healing wounds, a subsequent study, about a quarter of them had EPA in this study and about 75% didn't. But leg ulcers, that's venous leg ulcers, diabetic foot ulcers, traumatic and surgical wounds, and pressure ulcers all had roughly the same percentages of elevated protease activity. When you look at duration of the wound, I really thought that the earlier wounds would have EPA as opposed to older wounds, or maybe even reverse. But it turns out that there's no statistical difference between the ages of the wounds, and this data is based on quite a few patients, well over 100, and it seems that you can have EPA any time during the life of your wound. And I think a better way to think of EPA is the wound stalled? If the wound is stalled and non-healing, there's a fairly good chance that that's going to be the wound that has EPA. So now let's talk about protease modulation. We said that there's obviously wounds in the wound clinic, and there's quite a few wounds in the wound clinic that have elevated protease activity. So what are we going to do about it? It may not do us very much good to determine if we have elevated protease activity if there's nothing we can do. So what I'd like to talk about now is protease modulation. So here's a patient that has a chronic wound, and it looks like a venous leg ulcer. I wouldn't say it's infected. I wouldn't say it has elevated protease activity. You don't really know. Well, as I mentioned earlier, you can't tell if they have elevated protease activity or they have increased a particular bioburden. In this case, this patient had both an elevated bioburden and elevated protease activity. And it was with protease modulation with the addition of ORC collagen plus the silver component, they were able to take this patient to closure. Now, we still did all the same good wound care modalities. We still debrided the wound. We still maintained a moist wound healing environment. We still used compression therapy because there's venous leg ulceration, advised the patient to elevate their extremities, and all of that great wound bed preparation that has been talked about in the wound care community for quite some time. But it was really the addition of protease modulation and modulation of bioburden at this point that took this patient to healing. And actually the healing at this point was rather rapid, 6 to 8 weeks. So let's take a look at ORC collagen. That's oxidized, regenerated cellulose, and then collagen. About 45% of it's ORC, about 55% it's bovine collagen. It's bioresorbable and is an open pore matrix. You know, we've put collagen in wounds for a long time. Some of the early products for wound healing were actually collagens. It's a family of proteins with 28 members. It's found throughout the animal kingdom. The mammalian kingdom is highly conserved between species. You can use cow collagen or a variety of collagens from other animals. It has a lot of different benefits in the wound healing process. It can help to stop bleeding as a hemostat, enhances the deposition of new collagen fibers, reduces wound contraction. It acts as a substrate for cellular adhesion. In other words, it helps those fibroblasts migrate into the wound, and has a variety of other benefits. Now jump to the last bullet point there. It can act as a sacrificial substrate for excessive MMPs. So one of the things we were doing early on, and honestly at this point I'm not sure we really knew what the mechanism of action was for the collagen, was we put collagen in wounds, and we thought and we believed that and observed that we were affecting wound healing, and we were. And one of the things we were doing with the collagen is decreasing levels of MMPs. And that's because you put the collagen in the wound, and the MMPs break up the collagen. They eat the collagen. Instead of eating the patient, they eat the collagen, and that's what I mean by a sacrificial substrate. Now, ORC, or cellulose, is, again, it's the most abundant biomass on Earth. It's basically plant cell walls. Oxidation chemically modifies it and makes it biodegradable. And what it does is it deactivates those MMPs. Now, I mentioned MMP, that it's matrix metallo. And remember from the slides, I showed you the different types of MMPs. There was a ZN. That was the zinc. Matrix metallo, the metal in the MMP, is zinc. And zinc is very important for the activity of the MMP. So if we can disrupt the zinc in our MMP, we can inactivate it. And that's how ORC functions in decreasing MMPs. So looking at the benefits for healing, it inactivates proteases such as elastase and the MMPs. It also works as a hemostat, lowers the pH as it breaks down, which helps to control bacterial growth as well, because lower pH is going to inhibit bacterial growth. So there's several benefits of this very relatively simple product, ORC, in wound healing. So we have ORC and collagen, and we're going to put them together. And actually, if you look at the combination of the oxidized regenerated cellulose and collagen in combination, they actually bind more MMPs than either one alone. And this was shown in the early part of this century by Brita Cullen, who really showed that if you put them together, they work a whole lot better than if you put one in the wound and subsequently put the other in the wound. And hence we've come up with this combination product of ORC collagen, and then more recently ORC collagen with a silver component if you suspect, as you saw in that case earlier, that there may be a little bit too much bioburden. Not outright infection, but just too much bacteria within the wound as well. So looking at collagen ORC plus or minus silver, it rebalances the chronic wound environment. So it binds and inactivates proteases, both the MMPs and elastase. It protects growth factors. In other words, the growth factors are in the wound. If there's lots of proteases and MMPs and elastase in the wound, they're going to be broken down. So by adding collagen ORC, we're going to protect the growth factors. We're going to stimulate cell growth, both fibroblasts, endothelial cells, and keratinocytes. And if you have the silver component, it will be antimicrobial because there's an ionic silver. And also the ORC lowers the pH, as I mentioned earlier, and that's going to help us in controlling bacterial bioburden as well. So multiple functions of collagen ORC plus or minus the silver. Again, if you're talking about bioburden, we want to include the silver in this discussion. And all of these are going to lead to improved clinical outcomes. So let's ask a question. An ORC collagen combination dressing has all of the following characteristics except A, they stimulate cell proliferation, B, they must be used with silver, C, they protect growth factors, and D, they bind and deactivate matrix metalloproteases, or MMPs. And we should be able to answer that question at this point. All right, so let's look at some in vitro studies. Now, these aren't patient studies. These are just these are exposing the dressing to MMPs and elastase, and let's see what happens. So if you look at, in this case, ORC collagen with the silver, and you look at EPA, you can see that by putting chronic wound fluid and exposing the various dressings, you can see what level of activity you're going to have. So obviously the best results are with the collagen ORC silver or with the collagen ORC. Now look across there. If you put collagen only, or if you put collagen and silver in there, you really don't get the same effect. You really need to have that combination. It's the combination of collagen and ORC, collagen ORC silver that really makes the difference and decreases EPA. Clinically, you could certainly look at this and say, okay, well, it works in a test tube or in a lab. Will it work in my lab, which is the wound clinic? So here's a patient with a very long-standing venous leg ulceration. You can see at week 0, pretty large gator VLU. And what we see there is that the first line you see goes down, and that's a decrease in wound areas. The wound heals, but we're treating this patient with ORC collagen. And what you see is that there's a marked reduction in elastase and in the MMPs, and that correlates directly with the wound healing. There are a number of clinical trials, and you see that we have 7 randomized controlled trials with a a total of 569 patients. I can tell you that there are ongoing trials at this moment, and there are trials that have recently been completed that will be added to this list as well. But you can see that in in the first trial, venous leg ulcers, reduction in wound size, and a good healing response, and another venous leg ulcer showed a significant improvement in healing rates. There's 2 diabetic studies, one by Dr. Lazaro in Spain that showed improvement in complete wound closure, and in later DFU studies showing that it was really worked quite well in wounds that were younger wounds. And even in pressure ulcers on the last RCT, we can see some improvement by protease modulation. And that's really what we're talking about here. We're talking about modifying the environment, decreasing proteases. Now, here we see improved clinical efficacy with collagen ORC on wounds that we already know have EPA. So some of the research I just showed you, the RCTs, it was really before we were using EPA to guide us in our therapy. Now, what happens if we say, okay, we're going to use our ORC collagen or ORC collagen silver in wounds that we know have elevated protease activity? And that's what this next slide shows. And what you see there is all wounds. There's a 63% improvement in efficacy if you just throw ORC collagen on all the wounds. However, if we select out those wounds that we know have elevated protease activity, we get a lot better result. And that just makes good sense. We want to use these products on the patients that need them the most, and those are patients that have EPA. And so there was a 22% increase in efficacy when collagen ORC was targeted to the EPA wounds. And again, after 4 weeks of therapy, 80% of the wounds had a reduction in protease activity. Let's ask another question. According to a study by Cullen et al., which of the following statements regarding wounds with EPA are true? A, early treatment with ORC collagen significantly increased treatment efficacy. B, timing of ORC collagen application had minimal effect on treatment efficacy. C, ORC collagen should be reserved for wounds that fail to heal after 2 years. And D, patients presenting with wounds that have EPA are more likely to experience adverse effects when treated with ORC collagen. So let's look specifically at early treatment with collagen ORC. And what this paper by Brita Cullen has demonstrated is that actually you can further improve the efficacy and effectiveness of collagen ORC by using it early on. Again, there seems to be an early response. This is part of wound bed preparation, modifying proteases, reducing bacterial burden. And I think in the future, when we look at wound bed preparation, protease modulation will be part of that paradigm. In this, you see that there's 87% efficacy in wounds that are less than 6 months, and that drops off when you get to 2 years. Wouldn't it be great to find out the wounds that have elevated protease activity and then treat them specifically with protease modulation? I would bet that all of our products would work more effectively. And I can tell you anecdotally from the research that we've done that advanced wound care modalities work better if you protease modulate the wounds that have EPA. In other words, if you find a wound that has EPA, protease modulate, and then add your advanced wound care therapy, whatever it might be. We think those advanced wound care modalities will work a lot better. Now, let me just disclose that that's an anecdotal observation from a large number of patients, but not from a randomized trial or prospective study. So I want to caution you on that information. All right, so this next study looks just at that. Well, what if we know which wounds have EPA and we target that treatment with EPA? And this study that demonstrates that there's a significant savings. This was done in the UK, and if you can discover the wounds have EPA and protease modulate them, even if you can do something else after that, it's still very important for targeted treatment. Now, this is a patient from one of our clinical trials looking at ORC collagen with a silver component. And this is a venous leg ulceration. And if that doesn't look like a chronic wound, you've not seen a chronic wound. It is the granulation tissue at the base of this thing is pale. It's not the beefy red granulation tissue that my grandma used to call proud flesh. The epithelium is piled up on the edges, and the edge of the wound looks like a cliff. It ought to look like a beach, with the epithelium migrating nicely across the wound. There's probably too much bacterial burden. My guess is there's also elevated protease activity in this wound. And I will tell you, based on the results you're going to see in just a second, that it certainly did have EPA. Now, at 1 week, just the use of ORC collagen with silver component, we can see we've jump-started this wound. And I think that's something that we see when we treat clinically. When we see patients with EPA and then treat them with protease modulation, you do see an acceleration of healing. And that has really become the clinical picture that I've come to know and love, if you will. So here we are at week 1, same patient, and you can see the wound is not as deep, and the edges of the wound are beginning to change. It's losing that really super chronic appearance, and it's beginning to look like a wound that is responding to therapy. It looks like a wound that is starting to heal. Week 2, you see increasing amounts of skin, and particularly you're seeing islands of epithelium now developing within this wound. It's still not there yet. It still looks very chronic. There's more granulation tissue. It's not as healthy as we'd like. Some tissue that's not the greatest looking in the middle of the wound. Week 4, there's a 50% reduction in wound area. And for those of you who've looked at the guidelines the Wound Healing Society and other societies have published, you know that at week 4, if you get a 40% reduction in wound area at week 4, there's a very good chance, and it's over 50%, that wound will be completely closed by week 12. Now, this has been published, I think, a number of times. Peter Sheehan, I actually include that in this lecture for you to look at, has published these predictive values, and a number of other authors, David Steed, Marty Robson, Rob Snyder, have published looking at clinical trials and looking at surrogate endpoints. In other words, how much healing is occurring at week 4? And if I can look at week 4 and look at healing, then I can predict the wound healing at week 12 or week 16, whatever the particular paper used. In other words, what I mean by surrogate endpoint is that if something's working, we ought to know it at week 4. So if you add a modality to a patient with a stalled wound, by week 4, if the wound hasn't closed by 40 or 50%, or maybe even 30% if you want to be a little more conservative, then it's probably time for you to try something else. If you're doing basic wound care, wound bed preparation, and the wound's not responding like a lot of wounds don't, then that's a patient you may want to consider advanced wound care modalities on. After the next example, I've included Peter Sheehan's study, predicting healing based on healing at 4 weeks. Something I think everybody really needs to keep in the back of their mind when they're seeing patients in the wound clinic and trying to decide if your wound is responding to the particular therapy that you've chosen at the time. So let's look at a diabetic foot ulcer. Another patient from our clinical trial. This is a patient has a diabetic foot ulceration. Now, we went back and looked at this patient's healing rates, and actually we chose this patient for a particular reason. It's a pretty small ulcer. It's being well treated. It's been debrided. Moist wound healing is occurring, and he's getting very good offloading. He's got a fixed ankle walker, and he's wearing it. So we would expect that this patient would be healing normally. But as I told you before, in the 4 weeks prior to this picture that you're looking at now, the patient had no change whatsoever in the wound. So at that point, as I mentioned earlier, when we look at our surrogate, there's really no reason to persist in what we were doing. Now, we were doing good wound bed preparation, and we want to continue that, but we need to add something else because in those last 4 weeks, in this case 6 weeks, the wound has not progressed, so we need to add something. In this case, we suspected elevated protease activity. The patient was in a study which we're using ORC collagen, and we've added this to the regimen at this point, along with the other good wound care. We continued to debride the wound when we needed to. We continued him in his fixed ankle walker, and we made sure the wound was moist. If we had to add a little bit of moisture to the ORC collagen to keep it moist, we did so. You can see at week 2, the wound area has definitely decreased. A little bit of maceration. That's my fault. I was using an adhesive. He was having a little bit of difficulty with the dressing kind of sliding around the edge of his foot, and so I added an adhesive on top of the dressing, and what it did is it macerated the wound edges. Now you can see that despite my use of this adhesive dressing, that the wound actually is decreased in size, a little bit too macerated. So we would debride off a little bit of that callus, and again we measured the wound much smaller. And at this time, you can see that wound's already responding. So you would think that the defect in this wound, early on I talked about the underlying defects in wounds that we need to try to correct to get them out of that inflammatory phase of wound healing and into the proliferative or reconstructive phase of wound healing. And in this case, it was most likely high levels of proteases. And at week 4, the patient went on to complete closure. And this particular patient, I have to conclude that it was probably EPA that was keeping that wound open. good basic wound care had not taken him to complete closure. Fortunately, here we used protease modulation early in his care. Now, I don't expect that all of your diabetic foot ulcers are going to heal in 4 weeks by simple protease modulation. Protease modulation is one tool in our armamentarium that's going to help us to heal chronic wounds. But if it happens to be the only defect in that diabetic foot ulcer that you haven't corrected, in other words, you've got the offloading corrected, you've got the wounds got the proper moisture balance, it's got the proper reduction in bile burden, all you have to do is protease modulate. In this case, it went on to complete closure very nicely. I've included this work from Peter Sheehan in the review. I think it's a good thing to look at and to know. I think surrogate endpoints are becoming more and more popular. In this particular study, what he's shown is that wounds that achieved less than 53% closure at week 4. So in this case, it was less than 53% closure at week 4. As I showed you from the venous leg ulcer, that wound had closed about 50%. The diabetic example I used, he'd actually completely closed in 4 weeks. But let's just say, for argument's sake, that he had closed 50% as well. Then there's a very high likelihood that that patient's going to go on to heal at 12 weeks, and that's the first bar. So under the first bar, you see a greater than 53% area reduction at 4 weeks corresponds to a 58% chance that the patient will be completely closed at 12 weeks. And so the 4-week point is a very good surrogate marker for your therapy. Now, what if it doesn't? What if there's less than 53% area reduction at 4 weeks? Very unlikely that wound's going to be healed by 12 weeks. And so these patients are ones where we really need to think about it. So if you have a patient in the wound clinic and you've been treating with something, even if it's just basic good wound care for 4 weeks, and you've got about 5 or 10% closure, or anything less than 50% closure in that 4-week time frame, you need to be thinking about things like bacterial bioburden, elevated protease activity, and consider using advanced therapy. And in this case, in our clinics, with our experience with elevated protease activity in a very large number of patients, we start to think EPA, particularly if it's early on. So you take that diabetic I just showed you. We're doing a good job. Our doc in that clinic was doing a terrific job debriding and maintaining a good moist wound bed. We already treated the patient with a silver-containing product, which reduced bacterial burden and had good offloading, and the patient was actually being adherent with the offloading regimen. But the wound wasn't healing. In that 4-week time frame, it actually had healed 0%. It hadn't healed at all. The wound looked good, nice granular base, and the surrounding tissue looked good, but it hadn't healed. So if you go back to our graph now here, you can see he would fall in that second bar, less than 53% area reduction at 4 weeks. So if you're going to continue with that same regimen that you're just doing, which is good wound care, good wound bed preparation, there's only a 9% chance he'll be healed at 3 months. So 2 months from now, that patient's highly unlikely that he's going to be closed. We have to think about protease modulation. We have to think about that there may be elevated protease activity in that wound, and that's a patient in whom we've got to think early on, okay, we've done good wound bed preparation, except we may not have modulated the protease levels, and let's go ahead and protease modulate and see if we can make a difference. All right, I can tell you there's more evidence coming down the road. This is a clinical study looking at the efficacy and very importantly, the healthy economics. And we won't be reporting this one in pounds. This one will be in U.S. dollars, although it is a multinational study. And what we're doing in this case to really further demonstrate not only that you can detect EPA in the wound, but if you detect it and you modulate it, protease modulate, you decrease those proteases over a 4-week period, that you can get the wounds to go towards closure. In this case, we're going to look at that surrogate marker. We're going to look at that 4 weeks, and we're really going to look at that and see how well we can predict who's healed at 8 weeks or 12 weeks. So there's a couple different arms to the study. There's an EPA arm, and that's obviously elevated protease, and those are patients that we've tested that have EPA. And then if you have EPA, you'll either get standard of care, say it's a venous leg ulcer study, so they'll get compression therapy, or you'll get ORC collagen and standard of care. And then we're going to look at the difference between those two. To balance the study, those that do not have EPA are still going to be enrolled in the study. And similarly, they'll either receive ORC collagen plus standard of care, or they'll receive standard of care alone. And this arm will help us to really differentiate using EPA as a guidance to treat wounds that have stalled. So let me summarize at this point. So we mentioned proteases. Proteases are important. We need them for normal wound healing. They do a lot of very important things. And remember, from your polling questions, they're essential in wound healing. If I found a medicine that completely removed MMPs, you would not survive. But chronic wounds are characterized by an excess in these MMPs and neutrophil elastase, and they're very detrimental. And again, robust literature demonstrates that elevated protease activity is harmful to the wound. We've talked about how we measure protease activity. I introduced you to the concept of EPA, elevated protease activity, and right now in development, not FDA approved yet, is a point-of-care diagnostic that will swab the wound and see if that wound has elevated protease activity. It is my hope that we'll be able to use a test like that or similar to that, or other tests that may be developed in the future, and then be able to protease modulate based on the test. And as I showed you from the clinical trials, when you know a wound has EPA and then you protease modulate, you can really improve the healing outcomes. And again, in my opinion only, I believe that by testing for EPA, protease modulating, and doing that before we use advanced wound care modalities, such as our cellular or tissue products or negative pressure wound therapy, I think we're going to make these advanced wound care products work better. And I really think that detecting EPA and detecting infection in wounds is going to be the future of our industry. Again, remember, that's my opinion. Okay, we can control or reduce protease activity in chronic wounds. Again, that's protease modulation, and I would discuss at length ORC collagen. And then if you're worried that there might also be some residual bioburden, if there's too much bacteria in the wound, and I'm not saying an out-and-out infection, but too much bacteria in the wound, then we'll add silver to that and we'll decrease the amount of bacteria and bacterial proteases. I also mentioned that targeted and early adoption significantly improves outcomes, and it does. This is something in the future, I believe we'll be adding to wound bed preparation. Early on, the use of protease modulation, and it may be something we'll add to that regimen of debridement, moist wound healing, reduced bacterial bioburden, and offloading, or if it's a venous leg ulcer compression. That's been the standard pillars of basic wound care, and I suggest to you that perhaps adding protease modulation to that will also be important. As our understanding of wound pathogenesis increases, I think we can identify a number of new predictive markers. I think we're just at the beginning of developing point-of-care tests, and then we can link those to certain products. And in the field of cancer, for example, there are very specific products that are personalized to the patient. In other words, if you have a breast cancer, for example, and you have a certain gene type, HER, her new gene, you can take the medication Herceptin, and that's personalized medicine, and it's my dream that wound care will get there as well. Again, I think we can reset the standard of care and treatment of wounds. Again, we're going to personalize this medicine. We're going to use wounds based on what's wrong with the biochemistry, and there's a number of different investigators across the U.S. and the world who are looking at a variety of different biomarkers. I am firmly convinced, in my opinion, that the first one we'll be using is elevated protease activity, EPA. I think bacterial proteases also hold a lot of promise, and I'm really hopeful that someday we'll be able to develop a point-of-care test looking at bacterial proteases, and then we'll be able to modulate the wound. So if you have high proteases, for example, we can then protease modulate. If you have high bacterial proteases, then we can use something topical, either an antiseptic or, say, a silver or an iodine component, an iodine-type product that will reduce the bacterial burden. And I can see developing algorithms based on whether you have high proteases or high bacteria or some combination thereof. So personalized medicine, I think, will revolutionize wound care. I'm convinced. And I'm convinced the diagnostics will play an important role in that. And in my final statement being that, again, I think adding protease modulation to our basic wound care is really something that needs to be considered. I want to thank you. This concludes my presentation, and thank you for participating in this webcast.